I'm happy to have Professor Brunt Arslan from United States, as well as Professor Kumar, also from the United States. And we'll start with our first presentation, Dr. Waseema Ali. She will talk about management of dysfunctional AV fistula, stents versus balloons.
Hi again. My name is Waseema Ali. I work in Bart's NHS Trust. So today I'll be presenting the Dialysis Access Avengers, how balloon and stent superheroes saves a failing access. Every dialysis access story starts with the same enemy, neointimal hyperplasia, driven by shear stress, turbulence, and repeated cannulation, leading to stenosis, thrombosis, and access failure. We have to remember that no single hero can defeat every villain, so team selection matters. Let's get to know our team. The first hero here is the classic inflator, the plain balloon angioplasty. It comes with reliability, fast, it's everywhere, it has radial force, it's the first line treatment in almost all access stenosis. But we have to remember that the villain comes back as the high restenosis rate. The second hero is the muscle builder, the high pressure and ultra high pressure balloons. It comes with extreme inflation pressure. It's tough, persistent. We use it at fibrotic or calcified lesions. We use it in elastic recoil after the standard PTA and cephalic arch preparation. But it's limited because power without biology, this will lead to restenosis still. The third hero here is the precision blade, the cutting and scoring balloons. It comes with surgical discipline. It has microblades or scoring elements, and it controls the blade modification. We can use it at resistant weight lesions at the juxta-anastomotic stenosis and as a lesion preparation before the drug-coated balloon. This hero doesn't finish the fight, but it sets the stage. The fourth hero here is the anti-proliferation wizard, the drug-coated balloon. This is a biology. So if we have an neointimal hyperplasia problem, this has it's super powerful to work here. It comes with paclitic cell delivery. It has strategic timing dependence, so we need to inflate it very fast. We use it in dysfunctional native fistula, recurrent stenosis after good PTA results. Drug-coated balloon cannot fix recoils, sadly, and major dissection, and requires proper lesion preparation. Then we come to the armored shield, the cover stents. Its mechanical dominance, plus it restores the flow. It occludes any disease segment. Its personality is heavyweight champion. We use it at the AV graft, recurrence at the cephalic arch stenosis, and any flow-limiting recoil or rupture. Its weakness, it's very costly. It has edge stenosis and loss of future surgical options. So we call this hero only when mechanics defeat balloons. Then we have the experimental strategies, is the drug-eluting stents. It's off-label use and selected recurrent outflow lesions, limited but emerging evidence. So we need to battlefield our to map our battlefield, the dialysis access anatomy and needling zone. We should not place stents in preferred needling zones, preserve future cannulation sites. The cannulation sites should be straight, superficial, adequate diameter, and sufficient length, like 10 to 15 centimeter. So, if we are facing a juxta-anastomotic stenosis, who we should call? Our superheroes here should be, our first line should be high pressure balloon, like the Conquest or Atlas. If it's still there, resistant lesions, we will use the cutting balloons. If it's recurrent biology, then we will use the drug-coated balloon. And cannulation consideration here is very important to avoid stents or stent grafts to preserve for future revision. Here's a case of a juxta-arterial anastomosis. It's a brachiobasilic fistula, dilating the outflow vein with plain balloon angioplasty and high pressure balloon. Now I'm having a retrograde flow, so I'll go with my catheter to the brachial artery to find there still stenosis, angioplasty that, and then the problem if the inflow is solved. There is a radiocephalic fistula, which has clear stenosis after ballooning post. If we are facing a peripheral outflow vein stenosis, then the pathology here is cannulation trauma or neointimal hyperplasia, where the PTA can come handy and the ultra-high pressure balloon too. Drug-coating balloon, we use it if recurrent stenosis. So cannulation consideration here is very important. Here is a case of a venous stenosis, outflow, crossing, ballooning, and voila. Coming to the cephalic arch stenosis, here the pathology is high flow plus sharp angulation. It has a lot of elastic recoils and extremely high recurrence with PTA alone. So we think about stenting this very early. The best evidence-supported devices like Viaban or Fluency. Here's a case of cephalic arch stenosis after ballooning. Another one was ballooning. This is instant stenosis, where I used a drug-coated balloon to overcome this. And the flow after. So having the stenosis at the venous anastomosis with the graft. The pathology here is aggressive neointimal hyperplasia, poor PTA durability. So the gold standard here is the cover stent graft. The best here is to use Viaban or Fluency. A stent graft superior to PTA for target lesion patency. We have to think about cannulation consideration again. In arteriovenous graft, venous anastomosis balloons lose stent grafts win. Here's a case where there's a disruption between the venous and graft anastomosis and covered by a stent, Fluency stent. And there is a stenosis which managed by only balloon. For central venous stenosis, the pathology here is prior lines, elastic recoil, and external compression. Our superhero here is the first line, high-pressure balloon, Atlas, or Conquest. If we had a recoil or recurrence, then we can think about dedicated venous stent like Venovo, or stent grafts. The cannulation consideration here is not considered, as it's not a cannulation zone. And there is a case of central venous recanalization and stenting. Trying to cross and integrate with a CTO wire. Then coming from below with a stiff trauma. Finding the loop promising. Then snaring myself. Pre-stenting, ballooning. And then deploying a Viaban stent and a bare metal stent at the bottom, not to close the left side. This is another case of a total occlusion, crossing with a CTO wire and small balloon to facilitate the stenting. And this is a silver venous stent. So, we have a clear algorithm here, choosing your superhero. If you have an AV fistula, we should think about the location. For juxta-anastomotic, we should think about balloon or balloon cutting or scoring drug-coated balloons. If it's peripheral outflow, then balloon, whether it's plain or drug-coated if recurrent. Cephalic arch, stent graft early, and central venous, high-pressure balloon, then stent if recurrent. Regarding the grafts, venous anastomosis, then do stent graft first line. Protect the cannulation zone at any cost. Avoid treating cannulation segments unless critical. Match your device to the pathology and consider evidence grade. So PTA is the first responder, not always the final solution. And remember, a technical successful intervention that sacrifices cannulation is a clinical failure. Drug-coated balloon fights biology, not mechanics, so proper lesion preparation is essential. In cold stent grafts, when mechanic defeats balloon, cephalic arch, and arteriovenous graft anastomosis, and match your device to the pathology. These are the evidence summary, where superior target lesion patency with drug-coated balloon regarding the drug-coated balloon versus the plain, and stent grafts versus the plain balloon. In AV graft anastomosis, stent graft superior for patency. A stent graft versus the plain balloon, significant improvement in patency with stent grafts, and lesion preparation, improved acute success, facilitate drug-coated balloon, and dedicated venous stents, emerging data from recurrent stenosis. So identify the segment, start with plain balloon angioplasty, add muscle or blades if resistant, deploy the drug-coated balloon if biology dominates, escalate to stent grafts if mechanics dominates, and reserve the drug-eluting stents for selected complex recurrence. There is no single hero for failing dialysis access. Success lies in assembling the right team, matching device strengths to lesion behavior, anatomy, and evidence. Thank you.
Thank you very much. Our next speaker is Dr. Ahmed Kamel. He's going to dive in more detail of the drug-eluting balloons and